Hi, I'm Dr. Chris Ho, and welcome to part 2 of the presentation on fully edentulous treatment planning. In part 1, we focused on some of the restorative space requirements. We talked about the transition line and the lip support, and also about the dentofacial aesthetics and vertical dimension. In part 2, we're going to talk about the phonetics, how we set the teeth so that patients can enunciate and pronounce words correctly. We'll show you some of the different determinants which allow you the positioning of the teeth for vertical dimension and the height of the face. We'll discuss and outline what happens with bone once teeth are extracted. Especially when you're talking about fully edentulous patients, the amount of resorption that occurs is much more substantial than that of a single tooth case. And it's a continuing resorption that occurs. And then lastly, we'll talk about the numbers of implants that are required. Whether we're carrying out removable prosthesis or fixed prosthesis, what are the numbers that are required? What are the minimum numbers and what is the ideal numbers? So let's look at the phonetic sounds. And really one of the classic articles is the one by Pound in 1977. Let S be your guide. And S being your guide is really the closest speaking distance. The first sound we're going to look at is the F sound. So when patients say F or V, then this incisal edge of the maxillary incisal edges will touch the wet-dry line of the lower lip. So as you can see here on the image on the left, that maxillary incisal edge, as they say F, it will touch the wet-dry line of the lower lip. And we're going to see this in the video here.
Friendly fleas and fireflies.
So as the patient's saying F,
friendly fleas and fireflies.
You can see how the edge of those teeth
friendly fleas and fireflies
touch the wet-dry line
friendly
of the lower
fleas
lip.
and fireflies.
Now, the S sound is the closest speaking distance. And the S sound is an important sound to ask the patient to say. So as you can see, as she says the S sound, the teeth just about touch.
She sells seashells on the seashore. The shells she sells are seashells, I'm sure. And if she sells seashells on the seashore, then I'm sure she sells seashore shells.
So you can imagine if you open the vertical dimension too much and you encroach on the freeway space, then you may run out of room to form those S sounds. So the patient might have trouble saying the S sounds because you've encroached on that freeway space. So when you look at spear education, they talk about when patients say the S sounds, 70% of the S sounds are pronounced with incisal edge pretty much on top of each other, while about 30% of the patients, when they say the S sounds, they're more in a class 1 type relationship. So as I mentioned, if you encroach on the vertical dimension, if you open the vertical dimension too much, and the patient's struggling to form the S sounds, in the 70%, you might adjust the lower teeth to give them more space to enunciate the sounds. While on the 30%, you can actually reduce some of the palatal aspect to give them more space. You don't want to adjust the incisal edges of those teeth, which would reduce the aesthetic appearance of them. So in that type of patient that says the S sounds in a more class 1 type relationship, you have ability to adjust the palatal aspect of the tooth to give them freeway space. And then the final sound is the M sound. And the M sound is the mandible in rest position. Just like what I showed you with the teeth in repose, just the same with freeway space, we ask the patient to say the M sounds or the M sound. So as they say the M sounds, the lips are at rest, it gives you the repose position, but it also gives you that postural jaw position, that postural rest position. So it will give you the amount of freeway space that you have available that you need to determine for vertical dimension. So now we're going to talk about the amount of bone that you require. So when you evaluate a case, when you look radiographically, how much bone do you actually need for implant placement? And what happens to bone after teeth extraction? When teeth are extracted, we know that there's resorption of the bone. Schropp in 2003 looked at what happens to the bone radiographically after a tooth extracted in the premolar or molar region. About 30% of the width of the bone gets reduced. By 12 months, about 50% of the width. So there's significant resorption of the alveolar ridge after a tooth is extracted. And we all know the classic studies by Rougeau and Lind in 2005. When teeth are extracted, what happens to the bundle bone around the teeth when being a thin buccal plate? We see this typical resorption pattern that occurs. So one of the classic articles is this article by Torgren in 1972. And they looked at the continuing reduction of the residual alveolar ridge in complete denture wearers. And they looked at this over a period of 25 years. And what they found was that each patient had a continuous reduction that did not stop, and they had the same resorption pattern over time. What happened also was the mandible resorbed at 4 times the rate of that of the maxilla. So overall, over 25 years in the maxilla, you'd lose 2.5 to 3 millimeters, while that in the mandible lost 9 to 10 millimeters. And what that means also is as the mandible and the maxilla resorb, they resorb in different patterns. The maxilla resorbs pallidly, while in the mandible, it actually resorbs more buccally. So you see this type of relationship change. You see a more class 3 type relationship. So this may make your prosthesis in the maxilla more unfavorable because setting the teeth into a class 1 relationship means that you have much more cantilever type forces in the maxilla due to the resorption pallidly of the ridge. Kaywood and Howe in 1988 looks at this classification of the edentulous jaws, and they categorize the bone into basal bone and alveolar bone. Alveolar bone is that housing the teeth, and over time that alveolar ridge starts to resorb away. So the basal bone does not change shape significantly. So you see the basal bone is pretty much similar for every single patient. That's why Torgren studies showed that each patient had a very similar type of resorption pattern. The ridge changes shape both horizontally and vertically, and it's a very predictable pattern. So similar to Torgren, they had the same sort of conclusions in what happens to the bone resorption and ridge resorption. So if you look at the actual resorption patterns, they have a classification that often dentists like to use from class 1 to class 6. So the class 1 you can see is when the teeth are in place. The class 2 is immediately post-extraction. 3, 4, 5, you can see the resorption pattern that occurs both in the maxilla and also in the mandible. So the amount of bone that you require, it's pretty similar to that of conventional single tooth implants. We want to have at least 5 millimeters of width and 8 millimeters of height. Now, there are definitely shorter implants that can be used, but when you have a case that has shorter than 8 millimeters of height, then you might have to consider increasing the number of implants, so from 4 maybe to 5 or 6 implants, depending on the size of implants that you use. So let's look at the numbers of implants required in a full arch implant rehabilitation. I often get asked, is 4 implants enough? When do I use 5? When do I use 6 implants? When do I use even more implants? Although all-on-4 is an approach that I like a lot, there are some patients that may not be suitable for an all-on type restoration. So we'll talk about some of the times that you may have to increase the numbers of implants. Firstly, I want you to look at whether you're going to use a removable solution or a fixed solution. Now, I want you to become familiar with different terms. The first term is an implant retained overdenture. So that means that the denture is retained by the implants, but this prosthesis is tissue supported. In other words, as the patient loads the prosthesis directs its load on the tissues, so it's supported by the tissues. The denture is only retained by the implants. Now, the second option could be an implant-supported bridge. An implant-supported bridge would be supported by implants. It's not relying on the tissues to support the prosthesis, it's relying on the implants. So here, necessarily, you'd need to have 4 or more implants to support a prosthesis. And then sometimes you have both. You might have an implant overdenture, but it might be still supported by a milled bar, also having some tissue support as well. So you might have both options here, both tissue supported and also implant supported. So I want to highlight these 2 consensus reports. Marco Ricuzzo in 2012 looked at the optimum number of implants for removable reconstructions. They found there was no randomized controlled trials for the numbers of implants, especially in the maxilla, and whether you need to have any splinting. But 2 implants were very successful in the mandible. But there were long-term studies needed for maxillary overdentures. Maxillary overdentures have much higher complication rates, have much higher failure rates. Mandibular overdentures, there are now studies on 1 implant, which I'll show you. And what about the fixed reconstructions? So Guido Hideki in 2012, they also wrote there was a lack of evidence on the optimum number and distribution, with no controlled trials for the numbers of implants for fixed reconstructions. They also mentioned that full arch fixed dental prosthesis on 3 implants were not recommended. So let's go into a lot more detail about the numbers of implants for edentulous jaws. So when you're doing 1 implant, it would be an implant retained overdenture. It'd only be for the mandible. A single implant overdenture would not be suitable for the maxilla, as the bone quality is too soft. So in the mandible, it's a possible option to put a single implant in the central symphysis of the mandible to retain an overdenture. But more commonly is using 2 implants as an overdenture situation, possibly even 3, while in the maxilla, you would need to use at least 4 implants to use implant overdentures in the maxilla, and I would recommend splinting those implants together. Now, what about fixed prosthesis? There have been use of 3 implants to support fixed prosthesis in the mandible only, and that's what we call the Novum approach, and more recently, trefoil is another approach, but probably more commonly is 4 or more implants used to support a fixed dental prosthesis. So let's look at some of the advantages and disadvantages of fixed and removable solutions. If you're carrying out full arch treatment in a fixed case, you may have to use 4 or more implants. Your stability of your prosthesis is very high, but you are limited by your cantilevering because your position of your implants dictates how long your cantilevers can be. In a removable situation, you can have 1, 2, 3 implants, and your overdenture is not as stable as that of a fixed prosthesis. But the tooth position is a lot more versatile because, remember, with a removable solution, you're getting some support from the tissue. So you can put you don't have to be so concerned about cantilevers. And also you can provide more lip support by having a flange. In cases where you have excessive loss of bone and soft tissue, you may need to use a flange, and in a case like this where you have a flange to support the lip, the patient can still clean effectively because as they remove the overdenture, they can access the bar and clean the bar correctly. Now, looking at the seal, a removable overdenture can seal a lot better than that of a fixed prosthesis. Some patients may have trouble with fixed prosthesis. They may have some bubbles appear as they speak, especially if you've created too much space underneath a maxillary prosthesis. There's too much space, then they'll have more bubbling as they speak. A fixed prosthesis is more minimal in terms of its bulk. You have to be also aware that oral hygiene can be a little bit harder in a fixed prosthesis because they'll have to use special types of floss or water picks to try and access and clean, while that of a removable prosthesis, they can remove and clean a lot more simply. And also a fixed prosthesis is much more costly for a patient to maintain because if something has to be replaced, if something fractures, a tooth chips, you have to take the prosthesis off and send it to the laboratory. Whereas in a removable overdenture, you can actually take it and give it to the technician a lot easier than having you to access all the screw holes to unscrew and remove. So let's look into more detail now about some of the evidence behind some of the single implant overdentures. So let's look at some of my colleagues' work from Australia. Glenn Littlelow and Patrick Henry carried out immediate loading of single implant overdentures. So they placed an implant and immediately loaded 25 out of the 28 patients, and they had a 100% success rate on loading of immediately loaded single implant overdentures. Bryant in 2015 also carried out a 5-year randomized trial to compare 1 or 2 implants for implant overdentures. And what did they find? Between the 1 implant group and the 2 implant group, they found there was no statistical difference after 5 years in the patient's satisfaction or the survival. But what they did find was that 1 implant overdenture case had more maintenance because what happened was they had more fractured dentures. So you can imagine having a single implant in the center, they had more rocking and they had fractures of the prosthesis in the center. So they recommended to have a framework, a metallic framework within the acrylic, which would reinforce the overdenture and maybe minimize the amount of fractures that occurred. But with a single implant overdenture, there's less cost for the patient, and also less time for the patient. Now, let's look at the 2-implant overdenture. And the 2-implant overdenture is really the conventional way of treating patients with overdentures. So this would be my treatment option of choice if I had to perform an overdenture for a patient in the mandible. And there's some conjecture as to where implants should be placed. Should they be placed in the lateral incisor position? Should they be placed in the canine position as an overdenture in these situations? I always tend to recommend placing the implants in the lateral incisor positions. And that way it means that if the patient ever wants to transition their prosthesis from removable to a fixed prosthesis, there's room posteriorly to place implants in the 4 or 5 position so that you could have an all-on-4 type prosthesis. One of the other theoretical advantages of placing your implants in the lateral incisor positions is there's less rocking. So if you place your implant attachments in the canine positions and the patient is functioning on the prosthesis, there is some rocking of the prosthesis. While if you place it in the lateral incisor position, it's in a more anterior position, there's less movement of the prosthesis in function. So you can see here this axis of rotation. So as the patient functions, just like a disc to end saddle, you'll see there's a bit of rotation around those attachments. So placing the implants in the lateral incisor position is probably a better option for your patient. If you're going to use a bar type prosthesis, this may not be so suitable for these sorts of cases because as the patient functions, there's more rocking around the prosthesis, and as it rotates around that point of rotation, you might get a point of weakness where it fractures because the acrylic is thin in that region. So I would recommend to either use locator attachments, or if you're only using 2 implants, it'd be only really between those anterior implants that you'd have the bar. So there would be some ability for the prosthesis to rotate. Don't have these extensions like this image where they've extended distally and tried to make a removable prosthesis. It's just a recipe for disaster in that you'll get some fracturing occurring. So I'm going to show you a case of how we use the locator attachments with an overdenture. This patient here came in unhappy with his implant prosthesis, but he had combination syndrome with the flabby maxillary anterior ridge. So as the patient occluded, the prosthesis tended to rotate, and in this patient, as they occluded together, they found that their prosthesis in the mandible, it disengaged the locator attachments because there was so much movement of the maxillary complete denture. As the patient masticated and the flabby anterior maxillary ridge, as it lifted up posteriorly, it dropped down. It allowed the prosthesis in the mandible also to rock, and it would disengage from the locator attachments. So the patient was undergoing a lot of wearing of the attachments. So if you look intraorally, you'll see the different attachments, and you can probably see one of the other reasons why this case had more problems was that not only did they have a flabby maxillary ridge, but in the mandible you can see the 2 implants, they're slightly divergent. Ideally, the positioning of the implants should be aligned so they're completely parallel so that the attachments can engage correctly. When implants are slightly divergent and not parallel in nature, with these types of removable prostheses, it will wear the different attachments. So sometimes dentists think that implants will be the solution for a patient. And oftentimes implants will help in this type of case because it's an overdenture, it's only implant retained. So being able to fabricate well-fitting, well-supported dentures is probably the first and most important aim in your treatment. So when you look at his prosthesis, these prostheses appear underextended. You can see previous repairs had been carried out. You can see some meshwork in the maxillary denture, but you'll notice that there's just poor retention was reported by the patient. You can probably see in this image here, as he bites down, his denture lifts off those attachments. So there's the OPG of the implants. New prosthesis was made, custom trays, wax rims, new MMR, and this patient, because of the flabby maxillary ridge, it was an open window technique to take the impression. So we have a mucostatic, so not applying any compressive pressure on the mucosa as we take the impression. And a Gothic arch MMR was undertaken for centric relation recording. So you can see the difference in the prosthesis. You can probably see, particularly in the mandibular prosthesis at the wax try, and you can see there's a completely different periphery, different borders of the denture, and you can see this is engaging now the new prosthesis. It has to engage the primary stress-bearing areas. So that buccal shelf retromolar region is a very important area to be able to engage, and the previous prosthesis was not fitting so well because it wasn't really a well-fitting tissue-bearing denture. So here on this image, these are the new prostheses once they're processed. You can see there's a nice lingual flange well fitting onto the retromolar pad, and also that buccal shelf region of the mandible. These are the primary stress-bearing areas, and your denture has to cover those areas to have good tissue support. We changed the locators. You can probably see there's new locators on the upper right-hand side. It's a shorter locator. The previous one was much longer, and because it was longer, it was having more troubles with the divergence of the implant. So we've changed it to a shorter height overdenture, and we've done a direct pickup in the mouth. So here what happens is we've made little vent holes in the prosthesis. You can see the little vent holes. We've mixed up acrylic and picked up these locator attachments inside the mouth, ensuring that we block out from undercuts. So these little white rings are the blockout rings that block out the undercuts within the overdenture. And we pick these attachments up directly in the mouth. And then we hopefully have a happy patient at the end, with good occlusion. And you can see really important is the design of your new prosthesis and being able to engage those attachments correctly. Now that the tissue support is much better, and also the occlusion is a lot improved by engaging more in the posterior teeth rather, in this case with the combination syndrome, having the occlusion more anteriorly. So we looked at the 2-implant overdenture. What about the 4-implant overdenture? We sometimes call this a bar overdenture, fixed removable solutions. Let's have a look at some of these examples. So this patient here, you can see she's unhappy with her teeth. They were failing in the maxilla, and we discussed the advantages and disadvantages of fixed versus removable, and this patient decided to have a fixed solution. So she received a milled bar with 4 locator abutments, and then we have the prosthesis that is fitting onto those locators. And this patient has been functioning with this for close to 10 years now. Probably every couple of years we change those little attachments, and we change it as required. Probably a good tip that I can give you when you first give these to patients, maybe don't use all the attachments. There are 4 attachments. I sometimes will leave some of the processing attachments and put on 2 or 3 of attachments so that the patient gets used to taking them on and off. If you make it too tight for the patient initially, they get very nervous and anxious when they can't take it off. Particularly with these elderly patients, they may have difficulty taking things on and off. So get them used to doing this first with less retention, and then increase the retention as it's required. Now, we showed you one with a locator attachment, but I want to show you another case here where there was limited occlusal space. So this was a case that I completed many, many years ago before I used to carry out alveolectomy for more restorative space. And at that time, you can probably see the attachments now, instead of placed vertically, they're actually placed horizontally or pallidly. So these are Bredent attachments that are positioned lingually or pallidly, and they're allowing you a little bit more space. So here we've been able to gain a bit more space by not engaging them occlusally. So the next attachment I want to show you is the MK1 R.E. Burke design attachment. And this attachment is a very nice attachment because it's like a friction fit system, and it really feels like a fixed type prosthesis for the patient. So here, if I show you how this works, we carry out the implant treatment, and the difference with this is that the final bar has these little pins. When you need to lock the prosthesis in, you basically press on the lingual of that prosthesis, and the little pins fit into the metal bar in the patient's mouth. So it basically locks the patient in. But when they want to disengage and remove the overdenture, they use it like a little key, which pushes the pins out on the lingual, as you can probably see. And as they push out, once they push out, it allows the prosthesis to come out vertically. So it feels like it's fixed, but it's also removable for the patient. So with this patient with a severe resorption that's occurred, that's probably more than 10 millimeters, we need to have a removable type solution. And this solution here, you can probably see quite clearly in the images, there's the prosthesis fitting onto the bar, and it has the lingual pins, or in this case it's palatal pins. But when we want to lock it in, the patient squeezes on the palatal and pushes these pins into place. So as it locks into the milled bar, it also fits a snug fit on the anterior portion of the bar as well. So there's some mechanical friction provided by the bar, as well as the lingual sort of cross-pinning that's occurring from these metal pins. So you can see when the patient wants to pop them out, they can use a paper clip or this little key, they pop them out. Now I wanted to talk a little bit more about the maxillary overdentures. So Ragabar in 2014 did a systematic review, and they looked at the numbers of implants required, and the numbers of implants need to be 4 or more, and they need to be splintered together. And they had a success rate of greater than 95% when they did that. There was an increased risk of loss when they had less than 4 implants with a non-splintered anchorage. So with an overdenture, normally in the mandible, you don't have them splintered. They could be single individual attachments. While in the maxilla, after reading the literature, I would always recommend to splint the implants together and try to have 4 or more for a maxillary implant overdenture. So now let's talk about fixed implant supported bridge work. We're going to talk about the numbers of implants for fixed options. So 3 implants could be used for the mandible. Historically, we had the Novum approach. In the modern age, we have trefoil. We can use 4 implants, all on 4 type prosthesis, or we could use more than 4 implants. So one of the initial concepts was using 3 implants, and it was a concept called Brånemark Novum. Brånemark in the 90s analysed the skulls of different populations, different sex, and different age groups, and they found that everyone's mandible was very similar in terms of its dimensions. So he developed a protocol using a prefabricated templates and prefabricated milled bar that was made to issue to the patient on the same day. So basically what happened was that we placed a prefabricated template onto the patient's mandible, drilled the osteotomy site, and placed this bar that was immediately loaded for the patient. And this approach was used to minimize the number of implants and also minimize the cost of a treatment, and also immediately load for the patient. But they had some issues with these cases because of screw loosening. Sometimes the bars were not fitting, so even though there were templates made to fit to people's mandibles to drill through, just like guided surgery, there was still some misfit of the components. So we saw some fractured screws, screw loosening, those sorts of issues for the patient. In the modern age, there's been some new developments, and in the last 2 to 3 years, the Novum approach has really been transformed into a new approach called trefoil. And trefoil is once again using 3 implants. But the difference here was they had a different abutment system and a much more accurate fitting prosthesis and a smaller, less bulky prosthesis. So let's have a look at how this all works. So this is trefoil, so this is not Novum. So this was carried out probably 3 years ago now. And here in this mandible, the teeth were extracted, alveolectomy was performed on the ridge. You'll see the implants are now being placed with this template, and there's the implants in position. So using the template guides you for the position of those implants. So here we have the patient with the healing abutments in place, and this is the final bridge that was issued to the patient the following day. So this bar is not a milled bar, this is once again a prefabricated bar, but they have a unique ball and socket type fitting abutment system. So it's a bit like a ball that allows the bar to fit correctly that gets laser welded. So that's how they got around some of the problems of the misfit of the historical Novum type approach. So this patient walks out with this trefoil prosthesis in place with 3 implants in the mandible and a full arch fixed prosthesis. So that's what it looks like in the mouth, and we want to have some space for cleaning. Now, in the maxilla, we wouldn't do this, but in the mandible, the patient can clean more effectively with some spacing that's been left intentionally underneath the bridge. Now, trefoil is a relatively new approach, and the more conventional approach is Brånemark's approach. And the Brånemark approach has a lot of evidence over 40 to 50 odd years, and we place either 4 to 5 implants into foramina. And that's how I would, in my own practice, carry out the majority of my implant treatment in the edentulous mandible, 4 to 5 implants into foramina. One of the concerns of linking implants together in the posterior mandible from one side to another side is the potential for mandibular flexure. There's been a lot written in the literature of the flexure of the mandible, the medial pterygoids as they activate, as you open and close the patient, there's some flexing of the mandible. So there are reports that if you join implants from one side to another side in the posterior mandible, then you might have some discomfort for the patient. You may have some fracturing of the prosthesis. But these are more theoretical implications that argue against one-piece full arch restoration in the mandible. So what is your second option? If you want to place more implants, instead of 4, you want to place 5 or 6 implants. If you place implants above the mental foramen, if there's sufficient height of bone that you can allow you to place implants, then this is not going to cause problems in terms of the flexure of the mandible. There's not too much change in the mandible in this position. So mental foramen to mental foramen, if you're placing implants, this will not be such a problem for the patient. Now, option 3, if you're going to place implants in the posterior mandible, it may be best to segment the prosthesis. So in other words, you might have 2 implants in one side of the posterior mandible, you'd make a splintered bridge. On the other side, you'd make a splintered bridge. And then in the anterior portion, you'd have another separate segmented bridge. So here, in this situation, you'd actually have 3 separate bridges. So now we're going to talk about the edentulous maxilla. And the edentulous maxilla is a much more challenging jaw to treat, mainly because the type of bone that is there is much lesser in quality. You normally have type 3, type 4 bone. You also have the concerns of the bone atrophy as the bone resorbs. As I mentioned in the maxilla, it resorbs more pallidly. And oftentimes patients want teeth to look better aesthetically. We need to place teeth more labially to actually support the lip. And this means there's more cantilever forces on your prosthesis. So the teeth and their position in the maxilla are much more challenging and much more critical than that of in the mandible, because setting the teeth correctly in the maxilla influences the way the patients phonetically speak. So when thinking about the edentulous maxilla, Ed Bedrosian discusses the concept of using 3 zones. The first zone is that of the premaxilla, zone 1. Zone 2 is the premolars, and zone 3 is the molars. So when you have bone in all 3 zones, zone 1, zone 2, zone 3, you can place your implants axially. You can put 4, 6 implants, whatever you like, or you can even use the all-on-4 approach. While you have bone in zone 1 and 2, you might have to look at using the all-on-4 protocol, because here you can't place implants in the molar region. You're going to use an all-on-4 type approach. When you have bone only in zone 1, you might have to look at zygomatic implants. And those implants are much longer implants, 30 to 50 millimeters long, that engage the bone crest and also the zygomatic arch. But you would also link those anteriorly with some implants in the anterior maxilla. And when there's no bone in all 3 zones, then you might have to look at using quad zygoma. So the traditional approach, axial implants, you might place 6 implants. We have bone in all 3 zones. You could even use 8 implants if you wanted to and have a segmented prosthesis. If you have a case where there's only bone in zone 1 and 2, it's an all-on-4 type treatment. So if there's only bone in zone 1, then you'll be looking at anterior implants, and posteriorly you would place zygomatic implants. And these are 30 to 50 millimeters long that engage the zygomatic buttress and also the bone crest. And you'll see with zygomatic implants, they emerge more paddily. So you can see in the 1.5-1.6 region and 2.5-2.6 region, you can see the access point of the zygomatic implants are engaged more pallidly. If you have no bone in zones 1, 2, and 3, then you would look at quad zygoma as a treatment option for the patient. So in 2006, Jivraj in British Dental Journal looked at some of the treatment planning for edentulous maxilla. And they looked at particularly the cantilever forces if you place your implants in differing arch forms. So here you can see a square arch form compared to a V-shaped arch form. In the V-shaped arch form, if you don't have implants anteriorly, then you would have much larger cantilever forces applied to a prosthesis. So when thinking about numbers of implants, sometimes you have to add numbers of implants and not use the minimum number, because you might have cases like this one that has increased forces because of the cantilever of the prosthesis. Lastly, I'm going to talk about the all-on-4 treatment concept. And all-on-4 has been a very popular concept that was really developed by Paolo Marlo in 2003. So the principles behind the all-on-4 approach was that it was a graftless solution. It was to avoid having to carry out sinus augmentation or onlay grafting or even possibly nerve transposition. It was using 4 implants, and the most posterior implants were angled to avoid different anatomy. Also, you were able to provide immediate function with these 4 implants. And the 4 implants had to be spaced in the correct position. And I remember Marlo once talking about this. It's just like a chair that you're sitting on. The chair has the 4 legs, and the 4 legs have to be positioned correctly to support the load. And in this case, we have to place our implants in the right position so that we can support the load correctly. And that means that these implants have to be far enough apart. They have to have sufficient AP spread. So in the posterior maxilla, you need to engage the most distal part of the bone, avoiding the anterior part of the sinus. So these are angled. In this image, you'll see that a window is made in the sinus, so we can locate where the sinus is, and we're going to then place our implants anterior to that wall. And these are angled 45 degrees as a maximum, so anywhere from 30 to 45 degrees. And by angling these implants, one, you're placing a longer implant. Secondly, you're engaging bone more anteriorly, which has better quality bone than the posterior maxilla. And then also by angling your implant distally, you're also minimizing the cantilever forces because you're increasing the AP spread. Your implant being placed more distally increases that AP spread. So the AP spread is very important because remember, with cantilever forces, the cantilever forces are the most destructive forces in implant dentistry. It's a bit like a seesaw. So when the patient loads the prosthesis on the cantilever, it's applying compressive forces to the most distal implant and more tensile forces to the more anterior implants. But the most stress is always placed on the most distal implant. As a force magnifier, the longer the lever arm is, the more force that's applied. So a patient, if you place your implants all in a straight line anteriorly, the cantilever arm is so long, it increases the force, and that's where oftentimes people can get complications, is in this cantilever part of the framework. So the clinical studies have shown that tilting of those implants means that you reduce the cantilever length by about 6.5 millimeters in the mandible and about 9 millimeters in the maxilla. So significant reduction by distally angling those implants and tilting them in. Now, one of the concerns about cantilevers is this complication rate. And Surdo in 2009 looked at the 5-year survival rates of cantilever and non-cantilever prosthesis. And they found that the cantilever prosthesis had a 91.5% survival rate, while that of non-cantilever is 95.8%. So there was a higher incidence of complications for the cantilever type prosthesis. But they found that the bone loss was very similar. So the peri-implant marginal bone response was still good even with these cantilever type prostheses. So what are the appropriate lengths for the cantilevers? There have been many studies carried out with full arch cases with bilateral cantilevers with very high success rates. The original studies by Dell in 1981 and Albrechtsen have shown high success rates with these full arch frameworks with distal cantilevers, the typical Brandemark type approach with 4 implants placed interforamina. So other authors have looked at this, and there's very little good evidence as to what is the appropriate length of the cantilever, but most of the authors have recommended 15 millimeters in the mandible and about 10 millimeters in the maxilla in terms of the maximum length of the cantilever. There are other formulas that dentists use, and one of the formulas used is by Charles English in 1990, and he looked at a line taken between the most anterior and the posterior implants, looking at the AP spread, and 1.5 times that distance was the maximum cantilever length. Once again, very little evidence as to this formula, but it's one that's often used in terms of assessing how long your cantilever can be. So another question that often gets asked with this all-on-4 type restoration is, can you tilt the implants? What happens to the bone? Is the bone going to be maintained? Are you going to get more fractures of the components? Is there a higher stress that's being applied to the implants when these are all angled in place? So many authors have looked at the finite element analysis of the stress concentration being applied, and they found that the fracture of the components and the stress concentration really, in solitary implants, yes, it would be increased by having the inclination and angulation. It would be an increase in stress. But in these sorts of full arch rehabilitations where you are splinting your implants together and having cross arch stability, there's really minimal fractures, minimal change in that stress concentration to that of implants placed axially. The meta-analysis by Kranovich looked at 44 publications, and this was carried out in 2015, looking at both retrospective and prospective studies. And once again, they found that differences in angulation of the implants doesn't affect the implant survival or any marginal bone loss. So we know that tilted versus axially placed implants are just as successful. So finally, I want to conclude by discussing the numbers of implants that we use in the mandible and also the maxilla. So in the mandible, for removable type overdenture, we want to use 2 implants as a minimum. You can use 3 or more if you wish, but 2 would be a minimum. And this is well supported by the literature. For a fixed bridge work, we want to use minimum of 4 implants. In the maxilla, it's very different. As I discussed, in the maxilla, for a removable overdenture, I would like to use 4 implants as a minimum. That would be splintered together and supported by a bar. While that in the maxilla, I want to use 4 implants or more for a fixed bridge work. Now, we hear about the all-on-4 approach, and the all-on-4 approach is certainly an excellent treatment protocol. But what I don't like about this is that oftentimes dentists think of it like a cookbook recipe. They apply that same recipe for every single patient, and every patient is individual. Every patient has other risk factors, and they have other complicating factors such as parafunction. And you need to decide when is suitable to use an all-on-4 approach, or maybe it's 5 or 6 implants that you'll need to use. So I started this presentation by talking about how rewarding implant dentistry can be for these full arch cases. Certainly I've seen many patients over the years, they come back year after year, always thanking me for what I did for them all those years ago. But we know that some of the complications can happen with implant dentistry, especially these full arch cases. So hopefully this presentation is giving you some insight and an overview of how we go about treatment planning and how we can avoid some of these problems. Good luck in your practice, and I hope to see you in another presentation.